Hi, everyone. Thank you for joining our Diabetes Wellness webinar today. I'm very excited to introduce our speaker today, Warif Kastoun. She is a PGY1 ambulatory care pharmacy resident. She's currently rotating at Hoover Primary Care Clinic at Stanford and works alongside her preceptor pharmacist to manage patients with chronic conditions, including diabetes, hypertension, and hyperlipidemia. So today her talk will be about understanding lab values and adjunct medication in diabetes, so very important topic. If you have questions during the presentation, feel free to put them in the question and answer box on the Zoom link. You can also put them in the chat box, and then we will take questions at the very end, but feel free to put in questions during the presentation. So Warif, I'll hand it over to you.
Awesome. Thank you, Catherine. And thank you, everyone, for joining us today. Again, my name is Warif, and today I will be talking about understanding lab values and adjunct medication in diabetes management. So the objectives of our presentation today are to recognize essential lab values in diabetes and understand their clinical relevance, to interpret lab results using normal reference ranges, and also to explore adjunctive medications and their role in reducing diabetes-related complications. So we'll start with an overview of diabetes. Diabetes is a condition where blood sugar or glucose levels are too high due to problems with how the body uses or produces insulin. And managing diabetes involves usually multiple strategies, including medications, such as making sure that you are adherent to your medications and you are on the appropriate medications as well. Lifestyle changes, which include diet and physical activity or exercise, as well as regular monitoring, which includes the regular labs that you need to perform regularly. So why are medications needed? It's very important to understand that medications cannot cure diabetes, but they can delay or prevent health complications by helping keeping your blood sugars controlled. So diabetes increases the risk for other health conditions such as heart or kidney-related problems, and therefore additional medications are often needed to prevent those problems. So here I included kind of two pictures. So on the left, you see the different options to manage diabetes to lower blood sugar. Plus, most of the time, you will need additional medications to prevent the complications that can result from unmanaged diabetes. So we'll start by talking about the lab values that you need to manage your diabetes and why do these lab values matter. Lab values are one of the most important tools we have in managing diabetes. They help us in four big ways. So first, they guide the diagnosis and monitoring, so they let us track how things are going over time. Second, they tell us if the current treatment is working or if it needs adjustment. Third, they help us catch the complications early, such as kidney or heart issues, even before symptoms appear. And last but not least, labs will give patients something to understand and follow, which helps with the engagement and self-care. So remember, the goal isn't just to run the tests, but it is to use them to personalize the care and empower the patients. So this is an overview of the lab values needed in diabetes management, and I will go in more details about each of them. So first, starting with fasting plasma glucose or fasting blood sugar, which I'm sure if you have diabetes, you are well familiar with that. So what it does is that it measures your blood sugar when fasting, so before you have any meals. It can be measured using a glucometer, as you can see in the picture at the bottom. It can be checked at home or through a blood test at the lab. Fasting blood glucose will help with the diagnosis and also monitoring of blood glucose over time. It's typically monitored daily at home, or if it's done at the clinic or the lab, it's every 3 to 6 months. And it's usually depending on the treatment goals and the stability of your blood sugar. The goal is usually to have your fasting blood sugar between 80 to 130. And below here, I included the numbers that we look at to diagnose diabetes. So if your fasting blood glucose is below 99, this is normal. If it's between 100 and 125, this is called prediabetes, which is not quite diabetes, but it is you're at higher risk of developing diabetes. And then if it's greater than 125, this is where diabetes is actually diagnosed. A similar lab value, we have the postprandial blood glucose, which usually measures your blood glucose after eating. It can be measured using a glucometer at home or through a blood test at the lab. And this will help us actually assess your eating habits and as well as blood sugar response to your meals. It's typically monitored about 1 to 2 hours after meals to see how meals will affect your blood sugar. And the goal is to have it less than 180 because we expect that your blood sugar will rise after having a meal. Similarly, I included the numbers we look at for diagnosis. So if it's less than 139, this is normal. And then it's prediabetes if it's 140 to 199. And then it's diabetes if it's greater than 200. So this is just a summary of the target blood glucose levels that we look at. Again, if it's before your meal or when fasting, we look at 80 to 130. If it's after a meal, it should be under 180. And this is mainly because we expect your blood sugar to rise after eating a meal by 30 to 50. Again, I'm also sure that you might be familiar with A1C test, which usually measures the percentage of blood sugar that is attached to hemoglobin. So we call it glycated hemoglobin. And hemoglobin is the oxygen carrying protein in your red blood cells. So A1C measures the percentage of glycated hemoglobin over the past 3 months. And looking here at the picture on the right, so you see your red blood cell or the hemoglobin, and you see that sugar are attached to it. So the less sugar attached to it, the lower your A1C is, and the more controlled your diabetes or blood sugar. As more sugars start to attach to the hemoglobin, we'll start noticing a higher A1C number, meaning that your blood sugar is not very controlled. So here on the left, I included this donut picture. So think of A1C as a donut. The dough is your hemoglobin or red blood cell, and the syrup or the sugar are your blood sugar. So the more sugar coated your red blood cells, the greater the A1C value is, and the less controlled your diabetes is. So A1C indicates long-term glucose control compared to the fasting and postprandial blood sugar. It's typically monitored every 3 to 6 months, depending on diabetes control and what type of diabetes you have. And the goal is usually to have it less than 7%. For diagnosis, we look at these three values. So if it's less than 5.6%, it's normal. If it's between 5.7 to 6.4%, this is prediabetes. And then if it's greater than 6.5%, this is diagnosed with diabetes. So I also included this chart here that helps us translate the A1C into average daily blood sugar or estimated average blood glucose. So for example, an A1C of 7% roughly equals an average glucose of 154 over the past 3 months. This actually makes it easier for people with diabetes to connect their daily glucose readings with their lab results. So as you can see, for example, if you have an A1C of 8%, your average blood glucose over the past 3 months will be 183, which is typically higher than what we aim for. This is another lab test that is less common than the A1C, but we also use it sometimes. It's called fructosamine. So this is another lab that reflects the average blood sugar, but over a shorter period of time, which is about 2 to 3 weeks. And it reflects the glucose that is attached to serum albumin. So albumin is a protein found in your blood. It usually helps carry multiple things in your body, including hormones, vitamins, and as well as medicine. Um, which is albumin is different from the A1C, which reflects the glucose attached to the hemoglobin. So this test is specifically useful if A1C is not reliable. As examples are in patients with anemia or they had recent blood loss, so their hemoglobin is low and we can't rely on the hemoglobin to check their blood sugar. The general goal is to have it less than 285. And then as you can see in the arrow, if it's greater than 285 and up to 340, it's considered mild hyperglycemia or mild high blood sugar. And then if it's greater than 340, it means that you're most likely to have diabetes. So again, this chart will help us convert fructosamine levels into their estimated A1C and average glucose equivalents. It's useful for interpretation, especially when we are more familiar with the A1C goals. So, for example, if a patient's fructosamine is 325, that's roughly equal to an A1C of 8% or an average glucose of 180, which is also higher than what we aim for. So while fructosamine is a different test, the conversion will help us align it with familiar A1C based treatment targets. Next, I'm going to talk about creatinine. So creatinine is a waste product from your muscle breakdown. It's normally removed from the body by your kidneys. And serum creatinine or plasma creatinine or blood creatinine, it's a blood test that usually measures the amount of creatinine in your blood. It usually reflects how well your kidneys are filtering the waste. So the higher levels of creatinine may indicate reduced kidney function because now your kidneys are not able to clear the creatinine as it normally should. Creatinine is usually useful to calculate eGFR, which stands for estimated glomerular filtration rate. eGFR tells us how well your kidneys are filtering waste from the blood. We usually calculate it using this serum creatinine in addition to other factors such as age and body size. And it gives us a more accurate and standardized estimate of your kidney function across different people. So think of eGFR as your kidney score. The lower your eGFR is, the harder that your kidneys are working to filter out the waste. And the reason I am talking about creatinine is to introduce you to this important lab test that we also use in diabetes management, which is called urine albumin to creatinine ratio. So the name kind of give it away. It's a urine test and not blood test. It usually measures the amount of albumin in your urine compared to creatinine. So again, albumin is a protein that should normally stay in the blood. If it was found in the urine, it means that the kidneys are leaking this protein in the to the urine, which is a sign that your kidneys may be damaged. And we usually compare albumin to creatinine in the same urine sample to help us get a standardized ratio. It detects early kidney damage due to uncontrolled diabetes or sometimes high blood pressure. And the goal is to have the ratio less than 30. If it's between 30 and 300, this is considered mildly elevated. And then if it's greater than 300, this is considered severely elevated. And this test will actually guide our use for certain medications that can help lower your albumin levels and also protect your kidneys. This is to explain how healthy kidneys usually filter out the waste, but keep important proteins such as the albumin in the blood. So here on the left side, you will see that the filter is actually working properly. The proteins, which are these gray little circles, they stay in your blood and only the waste goes into the urine. While on the right side, you see that the kidney filter, you know that the kidney filter is damaged because you are able to see some proteins being leaked into the urine. This is what we called proteinuria, which means that you have protein in your urine. Now, moving on to another very important lab test that we do is the lipid panel. So lipids are fats and fat-like substances that are essential for building cells, storing energy, and also making hormones. In the blood, they include cholesterol and triglycerides. So the key components measured in the lipid panel are LDL cholesterol, which is the what we considered bad cholesterol, and having high LDL can contribute to plaque buildup in the arteries, which causes a high risk of getting a heart attack. The HDL cholesterol, which is the good cholesterol, it helps remove the LDL from the bloodstream. And then we have triglycerides, which are a type of fat used for energy. If we have elevated levels, that can increase the cardiovascular and pancreatitis risk. And then we also have total cholesterol, which is just an overall measure of the cholesterol in the blood. So why do we check a lipid panel? Mainly to assess for cardiovascular risk, as well as to monitor response to lipid lowering therapy if you are on any medications to lower your cholesterol. So people with type 2 diabetes are considered at high cardiovascular risk, even if they haven't had any heart event yet. So we routinely check lipids to assess the risk and monitor the response to medications such as statins, which I will talk about in the upcoming slides. And that's why lipid management is a key part of diabetes care, not just to meet the numbers, but also to prevent future heart attacks and strokes. And this slide will show you the target cholesterol goals that we aim for, especially in patients with diabetes who are at increased cardiovascular and those who are at increased cardiovascular risk. So looking here at the LDL cholesterol, normally we want to have it lower than 100, but if you have diabetes, the goal is to have it less than 70. And then for those who had previous heart attack, stroke, or other cardiovascular events, then we would like it to be less than 55. And this is just a summary slide of all the lab values that we look at, which I've already mentioned, but just to go over the frequency. So A1C, usually we would like it to be checked every 3 to 6 months, more so every 3 months until your diabetes is at goal. Fasting blood glucose, should be checked daily. Urine albumin to creatinine ratio, this is annually, as well as the lipid panel, which is checked annually. And just note that the target values may be individualized depending on the stability of your diabetes. So next we'll move on to talk about adjunctive medications. Now that you know what lab values we need to manage diabetes, we'll dig deep into the medications. So before I talk about the adjunctive medications, I just want to quickly highlight that we often choose anti-diabetic medications based on other health conditions and not just blood sugar. So a lot of blood glucose lowering medications have added on benefits other than lowering your blood sugar. So, for example, if a patient has heart disease, kidney issues, or even wants to lose weight, then certain medications such as the SGLT2 inhibitors or GLP-1 receptor agonists, which are very familiar nowadays. These include the Ozempic and Mounjaro medications. These medications may be preferred if you have other comorbidities. This approach will help us personalize treatment and also manage more than just the diabetes. So, you may ask why more medications are needed other than those that we choose to lower blood sugar. So, diabetes is not just about blood sugar, it's also a major risk factor for heart disease. So, ASCVD or atherosclerotic cardiovascular disease refers to a history of cardiovascular event such as a heart attack, stroke, or angina. And it's actually the leading cause of death in people with diabetes. And this is why managing diabetes means more than just lowering the blood sugar. We also need to control blood pressure, cholesterol, and weight to reduce this cardiovascular risk. And that means, and that's where some of our adjunctive medications come in, such as statins, ACE inhibitors, which I will talk about in a second, mainly to help protect your heart and your kidneys as well. So, to lower the risk of heart attacks and strokes in people with diabetes, we focus on these kind of three key areas: blood sugar control, blood pressure management, and cholesterol reduction, which are known as the three pillars of ASCVD risk management. And they usually work together to protect the heart and blood vessels. And that's why you will often see medications added, not just for glucose, but also to help with blood pressure and LDL cholesterol, even if those numbers are not actually very high. So these are the medications that I will be talking about today, which are considered the adjunctive medications. And they are the ACE inhibitors or ARBs, statins, and also Finerenone. So here I just included examples of ACE inhibitors and ARBs. So ACE inhibitors include lisinopril, ramipril, enalapril, benazepril, and quinapril. And then ARBs can include losartan, valsartan, olmesartan, and irbesartan. And you usually get prescribed one of these medications, either ACE inhibitor or ARBs, because they work similarly. So how do they work? They actually, the ACE inhibitors, they block an enzyme that forms the angiotensin 2, and ARBs will block the angiotensin 2 from binding to its receptor. So in kind of like simpler terms, both of them will relax the blood vessels and lower blood pressure. So usually these medications are recommended in patients with diabetes as well as chronic kidney disease, specifically if you have proteinuria, which is protein in your urine, even if your blood pressure is at goal, because eventually they help slow the progression of kidney disease. How these medications are taking, usually it's a tablet medication taking once or twice a day. They can be taken with or without food, but it is important to try to take it around the same time every day. Some of the side effects that these medications may or may not cause are dry cough, and this is mainly with the ACE inhibitors. So most of the time, if patients experience any cough on these medications, we switch them to ARB medication. They may cause dizziness because they do lower blood pressure. They may cause high potassium levels, and a rare side effect can cause swelling of the lips. So again, why do we need to take ACE or ARBs? Mainly to lower blood pressure, to protect your kidneys, to prevent or treat heart failure if patients have heart failure, and also to reduce the risk of heart attacks and strokes. Next, we'll talk about cholesterol-lowering medications. The very common medications are statins, including atorvastatin, rosuvastatin, simvastatin, pravastatin, and etc. And then we have other medications that are non-statins, including ezetimibe, or a class of medication called PCSK9 inhibitors that include elrocumab or evolocumab. So how do these medications work? They eventually, all of them lower LDL cholesterol. Statins will block the cholesterol production in your liver. Ezetimibe will block the cholesterol absorption in the gut, and then the PCSK9 inhibitors will help the liver remove more LDL from the blood. So how these medications are taking, for statins and ezetimibe, these are oral medications available in tablets. They are usually taking once daily. And the PCSK9 inhibitors, these are actually injections under the skin, and usually they are every 2 to 4 weeks, injected every 2 to 4 weeks. Some of the side effects that each medication can cause. So for statins, they can cause muscle pain, liver changes, and rarely they can cause muscle injury. For ezetimibe, they can cause or it can cause stomach upset, and also rarely any liver enzyme changes. And for the PCSK9 inhibitors, they can cause injection site reaction, as well as cold-like or flu-like symptoms. And that's why we actually check the lipid panel when you get started on any of these medications to ensure that they are working to lower LDL, but at the same time, they are not causing any harm. So why they are taken? Because they will lower the LDL or the bad cholesterol, as well as they reduce the risk of heart attack, stroke, and also heart disease. Next, we'll talk about Finerenone, which is another adjunctive medications that is taken to protect your kidneys mainly. Um, it blocks a hormone called aldosterone, which can cause scarring and inflammation in the kidneys and heart. So when blocking this hormone, it helps protect your kidneys and heart from future damage. This is usually a tablet medication. It's taken once a day. The dose might be adjusted based on your potassium levels and your kidney function. And some of the side effects that this medication may or may not cause include high potassium, can lower blood pressure, and it can cause dizziness, especially when starting the treatment. So why this medication is usually prescribed and needs to be taken is to slow the progression of chronic kidney disease in people with type 2 diabetes. It can also lower the risk of kidney failure, heart attack, and hospitalization for heart failure. So in summary, why does this all matters? So lab values will play a key role in assessing diabetes control and helping prevent serious complications from unmanaged diabetes. And knowing what medications you are on and why they are prescribed is a key to prevent long-term complications of diabetes. And that was all I have for you today. Thank you so much for listening, and I can take any questions.
Great. Thanks, Tori, for your insightful presentation. We do have some questions. First one is about medication interactions, specifically about amlodipine and related medications. Patients asking if you need to be worried about interference with diabetes medications.
That's a great question. So, for those who don't know, amlodipine is a medication taken to lower blood pressure. It does not have any effect on blood sugar. Great question. It does not interact with any of the diabetes medications. A lot of time, if you don't have any risk of getting those complications that I just mentioned, we see amlodipine get prescribed to lower blood pressure. But it is very safe medication to take with your diabetes medications.
Thank you. We have another question about, I think about diagnosing. So, can you tell us a little bit more about A1C versus fasting blood sugar, especially if someone's fasting sugar is between 90 and 100? What might that mean?
Yeah, great question. So again, I can go back to the slide. So fasting blood glucose just tells me what's your blood glucose today. So you wake up today, you're fasting, you haven't eaten any meals. Um, you check your blood sugar and it's between 90 and 100, which is normal. If it's less than 99. For A1C, it kind of like it's an average of blood glucose over the past 3 months. So if your A1C, for example, is high, which is usually greater than 6.5%, it means that your blood sugar has been high every day for the past 90 days. So this gives me a bigger picture about how your blood sugar has been over the 90 days compared to fasting blood sugar, which tells me only your blood sugar today. So A1C is definitely needed when diagnosing diabetes, and this is what we want to look at when diagnosing diabetes.
Thank you. And then someone has a question about timing of medication. So, for example, if taking lisinopril or other medications and recommended to take medications around the same time, is there any leeway there? For example, if you're taking it 2 hours off compared to the previous day, how is the body impacted, if anything?
Yeah, that's a great question. So we mainly recommend, so each medication will work for a certain amount of hours, right? So the reason why you take your medication every day, it means that for until the next day, it's no longer going to be effective, and that's why you need to take another tablet or another pill for it to continue to work. So if the difference is like just a few hours, I would say 2 to 4 hours, that is okay. Um, it doesn't have to be exactly at the same time every day or at the same hour or minute. But when what we don't recommend is that you take it, for example, late at night and then you wake up the next morning and take your medication early in the morning, because at that time you still have some of the previous medication still in your blood, and now you're adding more medication. So we just don't want it to accumulate in your body or in your blood. Um, Other medications, more importantly, the diabetes medications, depending on which medication you take, but each medication has a certain way, or some of them has a certain time that you need to take it. So, for example, if you're taking glipizide, it needs to be taken before meals for the medication to be effective. Certain medications can be taken any time of the day. For the injectables, some of them are taken once a week. So depending on which medication you take. But the general rule of thumb is to always take your medication at the same time every day, meaning if you take them in the morning, always take them in the morning. If you take them at the night, always do so.
Thanks for clarifying. What about for medications such as metformin? Are you supposed to take it before eating or same time as eating? And if so, like, does it change your blood sugar at all?
Yeah, great question. So metformin is one of the medications that does not have a risk of lowering blood sugar too much, so it does not carry that risk. So in a sense of lowering blood sugar, it's safe to take it at any time during the day. We just recommend to take it with food because metformin has some side effects of can cause a stomach upset or stomach pain if not taken with food. So for that reason specifically, we always recommend to take it after meals.
Great. Thank you. And speaking of, you mentioned that this medication does not result in or very low likelihood to cause low blood sugars. Someone's asking what would cause someone's blood sugar to drop and how would you reduce that from happening? And what are kind of like the consequences of low blood sugars?
Yeah, great question. So, it's very important to know when you have low blood sugar and how to treat it. So, for example, let me start with that. Certain medications do carry a risk of lowering your blood sugar too low, such as insulin, if you're taking insulin. And that's why we recommend regular monitoring of your blood sugar to avoid having low blood sugar. Um, I'm sorry, I forgot the other part of the question, but let me talk about how to treat a low blood sugar. And I will refer back to the targets. So let's go to here. So if you check your blood sugar and it's less than 80, it means that your blood sugar is too low. And for that, you need to correct it and increase it to get it back to normal. So the way you correct your low blood sugar is to have some source of what we call fast acting sugar to make sure your blood sugar goes back to normal as fast as possible. And for that, you can have maybe a half cup of orange juice or any fruit juice. You can have a regular soda, not diet soda, regular. You can have glucose tablets, which are kind of tiny sugar tablets that are available over the counter. We highly recommend those because they are very handy. You can take them outside of the house, and you can take 3 to 4 tablets. Um, Once you do that, once your blood sugar is low and you took that source of sugar, you want to give it about 15 minutes for it to start working. After that, you want to check your blood sugar again and to make sure it is normal again, so it is above 80. If it's above 80, then we recommend for you to have a full meal after just to maintain your blood sugar at a normal level. If you checked it and it's still below 80 or 70, even after you've had that source of sugar, then we just ask you to repeat the process again. So go ahead and have another source of sugar, wait 15 minutes and check it again. Keep doing so until it's above the goal. If you, no, sorry, not above the goal, until it's normal again. If you happen to experience low blood sugar frequently, maybe this could be a sign that you are taking your medication dosing is not working for you, for example. So that's when you need to tell your doctor or provider about that in case there needs to be any changes to any of your medications. Sometimes you are having low blood sugar, but you don't have a glucometer or anything to check. Sometimes you will have symptoms of low blood sugar, and that can include, for example, being nervous, being shaky, being sweaty. So if you experience any of these symptoms, even if you don't have, we usually recommend that you check your to see how your blood sugar is. If you don't have the glucometer handy, if you're, for example, out of the house, then we recommend to treat anyways. Did I miss
Thank
any
you.
part of the question?
The only part is maybe some like consequences of low blood sugars.
Yeah, perfect. That's actually a great question. So you don't want your blood sugar to drop too low because eventually it can, the highest risk can cause or is coma. So if your blood sugar is too low, you might kind of lose conscious. And end up in coma. That's like the very serious consequence. Um, Even still more serious, but not as serious as coma, could be feeling confused. You might have seizures. You might start to having those like a fainty dizziness. So it's very important to treat low blood sugar once you have it. But again, it's very, very important if you're experiencing it more frequently to let your doctor know so they can treat that as soon as possible.
Great. Thank you. And last question for today. Someone is asking if for their cholesterol panel, if LDL, HDL, and triglycerides are normal, but total cholesterol is above limits, how does that affect diabetes?
That's a good question. So actually, the total cholesterol, this is just like an overall measure of how your cholesterols are. We mainly want to look at LDL. If your LDL is fine, your risk of having those heart complications is lower. But eventually, some other factors we look at is your age, other comorbidities. So sometimes, even if your LDL is normal, sometimes we also still like to prescribe an LDL lowering medication to prevent those. Complications. So, as I mentioned, we're not only looking to treat the number, but we're also looking to prevent those complications. But that's like very individualized, depends on other factors that we look at.
Right. Well, thank you so much, Maury, for your insightful presentation. Just so everyone knows, the recording will be available and it'll be uploaded on Stanford's YouTube as well as Stanford Health Library. So that'll be up soon. And then, yeah, feel free to tune in for our diabetes wellness webinars throughout the year. They're hosted the second Thursday of every month from 5 to 6 p.m. Thank you, Warif, and thank you everyone for joining.
Thank you, Catherine. Thank you, everyone. Have a great day.